evening to all of you. Today, our guest speaker for the day is Dr. Brady L. Steen from Chicago, USA. He's going to lecture us on management of myelofibrosis in 2023. This webinar is brought to you by Mumbai Hematology Group, supported by Novartis, and managed by Perfect Square. I thank Mr. Bhushan Kothawade, Ms. Lekha VK, Mr. Rahul Deshpande and the team Novartis, Mr. Yash, Mr. Kalpesh and the team Perfect Square, Executive Committee of Mumbai Hematology Group, our guest speaker for the day, Dr. Brady L. Steen from Chicago, USA, all our discussants who are themselves eminent hematologists and medical oncologists, and you participants for sparing your Saturday evening. Tomorrow, that is Sunday, 23rd of July, 2023, we have a webinar on adult ALL advances in management from 11:30 a.m. onwards by Dr. Joseph Maria Ribera from Barcelona, Spain. Let me introduce our discussions for the day, here displayed in alphabetical order. To start with, we have Dr. Chandran K. Nair from Malabar Cancer Center, Thalassery, Kerala. Dr. Deepak Charles from Aster Medicity, Kochi. Dr. Gopinathan M. from MGM Healthcare, Chennai. Dr. Humaira Nazneen from Dhaka Medical College Hospital, Dhaka, Bangladesh. Dr. Leo Prince Mathan from Rela Institute, Chennai. Dr. Manoj Unni from Amrita Institute of Medical Sciences, Kochi. Dr. Muhammad Rafai from Government Medical College, Calicut, Kerala. Dr. Parathan Kurunakaran from Cancer Institute, Adyar, Chennai. Dr. R. Prasanna from Kencure Cancer Center, Tiruchirappalli, Tamil Nadu. Dr. Shrikant Mullikrishan from Apollo Main Hospital, Chennai. Dr. Sunu Siriak from Amala Institute of Medical Sciences, Thrissur, Kerala. Now it's a time to introduce our guest speaker for the day, Dr. Brady L. Steen from Chicago, USA. Dr. Brady L. Steen is Professor, Division of Hematology Oncology, Department of Medicine, Finbuck School of Medicine of Northwestern's Lurie Cancer Center, Chicago, USA. He is a professor at Division of Hematology Oncology, Department of Medicine, Finbuck School of Medicine of Northwestern's Lurie Cancer Center, Chicago, USA. He is interested in clinical investigation within the classical myeloproliferative neoplasms. He conducts clinical trials for patients with myeloproliferative neoplasms. He previously served as a scientific co-chair for a multi-institutional study of the epidemiology of polycythemia vera. He previously served as a scientific co-chair for a multi-institutional study of the epidemiology of polycythemia vera. He was a panelist on the NCCN guidelines for myeloproliferative neoplasms. Today, he is going to lecture us on management of myelofibrosis in 2023. Well, thank you so much. This will be a pre-recorded webinar as our speaker is not able to join today. So kindly bear with us. We'll offer you the recording of the webinar. I will stop sharing over here. Mr. Kalpesh, you may start the recording, please.
So first, thanks very much for the opportunity to share my thoughts on the contemporary management of myelofibrosis. I'm sorry that I couldn't do a live video with you. I apologize for that, but this is the next best thing, and I'm happy to try to address questions by email if needed. So first, we're going to talk about myelofibrosis. And of course, myelofibrosis is one of the myeloproliferative syndromes, along with ET and polycythemia vera. And I always show this slide at the beginning of a talk like this, just to mention that these myeloproliferative neoplasms, ET, PV, and myelofibrosis, as this audience of hematologists is well aware, share a number of overlapping clinical features. Some degree of myeloproliferation, tendencies towards thrombosis or hemorrhage, varying degrees of extramedullary hematopoiesis, myelofibrosis, and the possibility for leukemic transformation. The first to recognize these shared features is shown here. This is Dr. William Damashek, and in the journal Blood in 1951, he speculated that these conditions, and he coined the term myeloproliferative disorders to describe them, were all variable manifestations of the proliferative activity of the bone marrow cells, perhaps due to a hitherto undetected stimulus. So not only did he classify these entities together, he speculated on a shared pathogenesis, and he was quite right, but it did take about 55 years before the first stimulus was discovered, and of course that was the JAK2, V6, and 7F mutation in 2005. So what I'd like to do is start with the case, and this is perhaps like one you've seen in your clinics. This is a 79-year-old patient. The patient had a prior history of MGUS, monoclonal gammopathy of undetermined significance, and developed mild anemia. His hematologist sent him for a bone marrow biopsy to exclude evolution to a plasma cell dyscrasia such as multiple myeloma, but he was actually found to have a hypercellular marrow with proliferating megakaryocytes, grade 2 fibrosis, and a JAK2 mutation. So his MDs were surprised. They were looking for myeloma, but they found primary myelofibrosis, and he was referred to discuss management. And taking his symptom inventory, he was fatigued with drenching sweats. He did have comorbid illnesses that can certainly be observed in a 79-year-old like this. No palpable hepatosplenomegaly. And his anemia actually resolved. It was kind of a transient temporary phenomenon. You can see his hemoglobin was 13.7. But he did have a slight white count increase, a slight leukocytosis. He had a normal platelet count, and on his differential, he had suggestions of leukoerythroblastosis. So he had nucleated reds, 4% myelocytes, and 2% metamyelocytes. So that case will frame a discussion of treatment, but before getting into treatment, let's talk about diagnostic criteria for myelofibrosis. And myelofibrosis actually has a spectrum. There's the early pre-fibrotic myelofibrosis, pre-MF as it's sometimes coined. And the criteria here is that a patient would have atypical megakaryocytic proliferation. They may not have bone marrow fibrosis. If they do, it should be less than grade 2. Otherwise, it'd be considered overt PMF. They often have an increase in bone marrow cellularity, a granulocytic proliferation, and a decrease in erythropoiesis. Certainly 90% of such patients have a mutation, either JAK2, CALR, or MPL. If they don't have one of those three, we hope to find another clonal marker by extended next-generation testing, sequencing. And then another important criteria is to try to rule out another mimicking myeloid entity. And of course, perhaps the most common mimic of early pre-fibrotic MF is essential thrombocythemia. The minor criteria that tell us it's more likely pre-fibrotic MF as opposed to ET would be the recognition or observation of anemia, leukocytosis, palpable splenomegaly, or an increased LDH. So that's a pre-fibrotic MF. But our patient had more extensive fibrosis, so he's better diagnosed with primary MF in the overt fibrotic stage. And the major criteria for diagnosis are shown here: megakaryocytic proliferation and atypia, with reticulin and/or collagen fibrosis at least grade 2. So that's the distinguishing feature compared to early pre-fibrotic MF. Again, just like pre-fibrotic MF, we hope to find a mutation, and we do in 90% of patients. And if we don't, we look for other clonal markers by next-generation sequencing or by karyotyping. And again, just in the same way, we have to exclude another mimicking myeloid entity. The minor criteria are the same: anemia, leukocytosis, palpable splenomegaly, and an increase in LDH. But what's different in the minor criteria here with overt fibrotic PMF is that we might see leukoerythroblastosis, or we often should see that because of the degree of bone marrow fibrosis. So in terms of the clinical complications of MF, this audience of hematologists is probably pretty aware of the clinical complications. And I show in this slide some of those, and they include most commonly splenomegaly. About 85% of patients will have splenomegaly, a slightly lower proportion, but a high proportion will have hepatomegaly. The next most common clinical manifestation at diagnosis is anemia. It's especially the case as the disease progresses, followed by constitutional symptoms. And then there are patients with thrombocytopenia, leukocytosis, thrombosis, and of course, over time, this MPN can have a risk for leukemic transformation. So in general, many patients, or most patients with myelofibrosis over time, develop symptoms. Of course, we do see some patients, and that might be the more earlier diagnosed patients, the pre-fibrotic MF patients that could have less of a symptom burden. We could see some low-risk patients that are diagnosed incidentally. Perhaps a scan shows splenomegaly, or a routine blood count shows a leukoerythroblastosis. Some patients, again, can be asymptomatic, but most patients, if you ask, and especially as the disease progresses over time, most patients have one or more of these main clinical complications, and they have a symptomatic illness. So in terms of prognostication, mutations really are pretty important for the myeloproliferative neoplasms, as you can understand. In myelofibrosis, the mutational profile is pretty important in terms of the driver mutation as well as the non-driver mutation or other somatic clonal markers. So first, if we look at driver mutations, the most common is JAK2, and that probably influences the prognosis most or more so compared to CALR. Calreticulin positive MF patients generally have a better prognosis. Patients with MPL, this is only a subset that of perhaps 5 to 8% of myelofibrosis patients, and they probably have a prognosis similar to JAK2, but it's such a small group that you have a difficult time really distinguishing their clinical course based on their mutation. So I sort of look mostly at JAK2 versus calreticulin, and there could be some patients who are triple negative. That's somewhat of a heterogeneous group. So we have the driver mutation, and of course that helps us with diagnosis and to an extent prognosis. And then we do additional molecular testing, and we know that if a patient has IDH, EZH, perhaps ASXL1, definitely SRS2 and U2AF1, they probably have a worsening prognosis if they have, in addition to their driver mutation, one or more of these high molecular risk markers. So this sets the stage for an evolution in prognostic scoring systems, and that's what we have. We've used a number of different prognostic scoring systems over time, but what I tend to use now is something called MIP70 or MIP70 Plus if you have the karyotype. And you can Google this, you can find the MIPS70 scoring calculator on the internet. So what I do is when I have a new consultation, I get the variables from the intake of the visit, and then I plug them into the calculator. And what you can see is that they are pretty comprehensive. And so for example, MIP70, and we're looking at this in transplant age patients mostly because I think the best use of these prognostic scoring systems is really to identify patients that have a high-risk prognosis, a shortened survival that may benefit from referral to a transplant physician. So if we look at MIP70, it includes some of the historical variables such as constitutional symptoms. We look at the depth and severity of blood count abnormalities, so anemia, leukocytosis, and thrombocytopenia. We look at blood blasts, but we also incorporate the molecular markers. And so it's worse if you have another mutation as opposed to CALR. It's worse if you're in a high molecular risk category. It's worse if you have more than one high molecular risk mutated genes. So it's pretty encompassing looking at clinical, demographic, and mutational variables. And so I tend to use this to select patients who might have longevity versus patients who might have a high-risk prognosis and could benefit from transplant. And the MIP70 Plus is a little different. It looks at the depth and severity of anemia by gender. It looks at the karyotype, and you can find in the calculator which features on the karyotype are unfavorable or very high risk. So the idea is when we assess prognosis, we've evolved to now include the molecular landscape that we identify in the patient. So in terms of treatment, we're going to next move through treatment. And again, I mentioned that the molecular markers are important in calculating a risk score along with the other variables that we discussed. And I use this to look for potential transplant candidates. Of course, high reward because it is curative, but very high risk, as this audience of hematologists is well aware. So, most patients with myelofibrosis aren't treated by transplant. About 5 to 10% of patients with myelofibrosis ever get to transplant. So in that respect, I focus more, especially on this talk and in my clinic, on the medical therapies for myelofibrosis. Transplant is complicated as it would be in any hematologic disease. In myelofibrosis, the additional complicated factors have to do with marked splenomegaly and fibrosis, which can delay engraftment. Like any transplant, there can be transplant-related mortality related to conditioning and GVH. There's a possibility for relapse, and that's balanced against the possibility of definitively addressing the disease burden. The challenge is to identify the ideal candidate and to time the transplant appropriately. And that's kind of where I use the molecular risk score as one feature to identify patients with high risk prognosis. So I'm not going to talk too much about transplant. I'm not a transplant physician. I'm more of a classical hematologist. So I bring this slide up because we can cure, but I focus on other aspects because 90% of patients are treated outside of the transplant procedure. So this is an algorithm or an approach to the non-transplant management of myelofibrosis. And first, we make goals for therapy. What are our treatment goals? Largely, the treatment goal is to ameliorate the predominant aspect of the myelofibrosis symptom or disease burden. And we know, that patients are often symptomatic. They have a lot of clinical manifestations. And what we try to do is prioritize which is the worst set of symptoms for them, knowing that there's often overlap. So for example, some patients who have low risk early asymptomatic MF, they could be candidates for observation, a clinical trial, or perhaps interferon. If things change, if they have a loss of response or progression, or they develop symptoms, I might treat based on the predominant aspect of the MPN burden, which I try to separate into those with predominantly constitutional and or systemic symptoms, often inflammatory or related to splenomegaly, and I view those patients as good candidates for JAK inhibitors, which we'll discuss. If they lose response, there are now other JAK inhibitors that have approval in many parts of the world, and there are clinical trials. Some patients really have a major priority as treating their anemia. Now, that's often not the only issue associated with their myelofibrosis, but sometimes that's the priority. Sometimes they're lacking significant inflammatory symptoms or splenomegaly. Sometimes it's really the anemia that we have to try to palliate, but that's really one of our most difficult goals. Here, I'd always look for a clinical trial up front, if available. Otherwise, I'd consider an erythropoietin stimulating agent if the erythropoietin level is low enough. I'd also consider drugs like danazol and prednisone, thalidomide and lenalidomide I use sparingly these days. I'm looking for better treatments for anemia, and one of those to watch includes the erythroid maturation agent called luspatercept that's approved in some parts of the world for thalassemia and MDS. So that's something that keep on your radar. When patients progress to an accelerated phase, again, I'd look for a clinical trial. Sometimes we can't find one, and we have to recommend the hypomethylating agent, such as 5-azacitidine or decitabine with or without a JAK inhibitor. So this is an algorithm, and of course I'm going to expand on that and really focus on JAK inhibitors because that's the class of medications that are approved for patients with myelofibrosis. And I'm going to start, of course, with ruxolitinib, but first, candidates for JAK inhibitors, and we have a lower threshold to treat because most patients are symptomatic, and sometimes they realize how symptomatic they were after you start treating them. So less and less am I observing patients, especially patients who have some degree of symptoms. So JAK inhibitors, useful for inflammatory symptoms and or splenomegaly. The inflammatory symptoms are listed here. Those might be fatigue, fever, weight loss, night sweats, and itching. Symptoms from extramedullary hematopoiesis, which this gentleman in this picture is really suffering from with hepatomegaly and splenomegaly. Good candidates for JAK inhibitors when they have a liver and spleen like this. Sometimes patients can have extramedullary hematopoiesis involving other sites like the pleura, the peritoneum, vertebral masses, or perirenal masses. These patients perhaps benefit from JAK inhibitors, but if they have an extramedullary hematopoiesis involvement of an unusual site like this, sometimes they need radiotherapy. So let's focus on JAK inhibitors, and let's start with the first approved ruxolitinib, which is a JAK1, JAK2 inhibitor. I think the audience here is probably very well aware of ruxolitinib. It's the JAK inhibitor with the longest approval, and its approval was based on the COMFORT studies, COMFORT 1 compared to placebo, COMFORT 2 comparing ruxolitinib to best therapy, and clearly compared to placebo or best available therapy, patients had reduction in spleen volume and improvement in symptoms, and we learned that the major toxicity would include myelosuppression, especially anemia, and to a lesser degree thrombocytopenia. Over time, we're pretty well aware that ruxolitinib increases weight, increases the risk for skin cancer, infections like zoster, and reactivation of tuberculosis. And there could be a withdrawal symptom telling us that if we have to stop, ideally we should taper. Now, ruxolitinib actually associates with a survival benefit. It's controversial because many people criticize the data because it wasn't that the initial randomized trials were powered to prove this, but there's post hoc and exploratory and registry data that suggest that compared to placebo or best available therapies, there is a survival benefit. And I've summarized some of the studies here. So is that intuitive? Yes and no. Intuitive in that this drug controls inflammation, improves splenomegaly, and patients live better. And if they're living better with an improved quality of life, then they're going to live longer. So intuitive in that respect. The survival benefit is more of an indirect effect, improvements of inflammation and quality of life, as compared to reduction in bone marrow fibrosis, reduction in molecular markers, or remission of the disease. So it's not that the patients live longer because they have histological or molecular changes. They're living better because of controlled inflammation, improvements in functional status, performance status. So generally I believe it, but I haven't always started a totally asymptomatic patient because of their survival benefit. So in terms of dosing, really dosing is based on the platelet count. And you can see, and you're probably familiar with dosing ruxolitinib, all of you have used this to treat myelofibrosis. We can't really, or we shouldn't really use it in patients who have a platelet count of 50,000 or less. So that's where we have to focus on another JAK inhibitor. That was an unmet need up until lately. In terms of infections, this is something to watch for. Thankfully, in my experience with ruxolitinib over the last 10 to 12 years, the most common infection that I've observed in my patients would be something like zoster or UTIs. I have not experienced or have my patients experienced serious opportunistic infections, although we're on the lookout. We are aware that if a patient's on ruxolitinib and has they are at risk for opportunistic infections, and so we often would have to involve our infectious disease colleagues if we're suspecting such an infection. Another important part that we learned about in the last couple of years is that ruxolitinib could impair the COVID-19 vaccine response. We did see some non-responders by antibody titer with ruxolitinib. So let's go back to our case. This was the 79-year-old with MGUS who was actually found to have PMF. He had okay blood counts and no palpable splenomegaly, but a lot of inflammatory symptoms. And so I felt that this patient was a candidate for a JAK inhibitor based on inflammatory symptoms. I have used even in the absence of symptomatic splenomegaly. So you don't have to have splenomegaly to use ruxolitinib. If the patient has inflammatory symptoms, I still will use this drug to try to control inflammation and address sweats and fatigue as it did in this case. So let's move to the next case. This is a patient with myelofibrosis, a 69-year-old with a calreticulin mutation, on ruxolitinib, started 4 years ago, presents for a second opinion because of progressive splenomegaly, night sweats, and leukocytosis. So symptoms that were previously controlled but now have reappeared. The patient has comorbid illness and is not considered for transplantation. The spleen is indeed palpable, 7 centimeters below the costal margin. And the patient has a very prominent leukocytosis, a mild to moderate anemia, and a thrombocytosis. So what would you consider next for this patient? So the next approved JAK inhibitor that I would consider for a patient like this in my own clinical practice is the JAK inhibitor fedratinib. This is a JAK2 FLT3 inhibitor. Its approval was based on Jakarta, a clinical trial that compared fedratinib to placebo. And in Jakarta 1, the 400 milligram daily dose, which is the approved dose in the United States, this drug resulted in better spleen volume reduction and symptom improvement compared to placebo. The toxicities are somewhat similar to ruxolitinib. Myelosuppression, so to a similar degree of myelosuppression. The unique toxicity is gastrointestinal. So you really have to watch for gastrointestinal symptoms or side effects in these patients and preempt with an antidiarrheal and an antiemetic at first onset or even before they have these symptoms if you're going to be more aggressive. Jakarta 2 is another study that contributed to approval. This study looked at patients with prior Rux intolerance or resistance, and it was a phase 2 study. Initially, the data were incomplete. This drug went into a long clinical hold by the US Food and Drug Administration due to concerns over encephalopathy. But years after this hold, looking at the data, it was felt that there was not a cause and effect between this drug and encephalopathy, so it's ultimately approved. And the data have been looked at again, and with rigorous criteria for drug intolerance or resistance, what we can see is symptom improvements in 27% and spleen volume reduction in 30%. I think that's fairly impressive if we look at a Rux-resistant population. So I view this as a salvage drug, especially if it's the spleen that's causing problems. Similar toxicities as ruxolitinib, similar toxicities as you might see presented in the Jakarta-1 compared to placebo. So for fedratinib dosing, again, 400 milligrams daily. This drug also requires a platelet count of 50,000 or more. You can reduce for cytopenias. You can interrupt for GI toxicities, but you also uniquely must monitor thiamine levels before treatment and during, because the clinical hold had to do with the possible association between encephalopathy and this drug. It was not found to be a causal association, but the risk mitigation strategy was to monitor thiamine levels prior to and during treatment. And if encephalopathy was to occur, of course, to stop therapy and give parenteral thiamine. And so for this patient, this is a patient that has lost their response to ruxolitinib, the 69-year-old with a CALR mutation who had progressive splenomegaly after 4 years of disease control. So here I introduced fedratinib. Of course, a clinical trial is another option, but clinical trial access is different or difficult in all parts of the world. So not many patients, or not as many patients as we would like, get to clinical trials. So let's go over another case. This is a third patient. Let's say that the patient is similar in that they have a calreticulin mutation, that they had a previously good response to ruxolitinib, but they have progressive splenomegaly, night sweats, and leukocytosis. But now when we look at their CBC, their complete blood count, they have significant thrombocytopenia, so a platelet count of 41,000. So what options would be available in my clinic? So here, pacritinib. This is, in the United States, the most recent drug approval. This is a JAK2 FLT3 IRAK1 inhibitor. And what's unique is that a target called IRAK1 is addressed by this drug. It's a downstream mediator of toll-like and interleukin-1 receptor signaling, which contributes to NF-kappa B activation, which is a key regulator of MPN inflammation. So inhibition of this kinase could ameliorate MPN-associated inflammation. And the perhaps practical, most unique part of this drug is that it can be used in a patient with any platelet count. It's not suppressive on the platelet count like the other drugs could be. So in PERSIST-1, there was a comparison between this drug and best available therapy, and there were spleen volume improvements and symptom improvements. In PERSIST-2, the focus was on patients who had thrombocytopenia, and the comparison was best available therapy allowing for a patient to be treated with a JAK inhibitor. And here we saw better performance in terms of spleen volume reduction, non-significant improvements in symptoms, the toxicities, a little myelosuppression, but most of these patients were myelosuppressed or cytopenic to begin with. The unique toxicity was gastrointestinal, like it was with fedratinib. Another dose-finding study, a safety-finding study, PAC-203, comparing 3 different dosing regimens, and the approved dosing regimen is 200 milligrams BID, showed that there was better spleen volume reduction at 200 milligrams BID, similar symptom improvement, adverse events, cytopenias, but most had these at baseline, gastrointestinal toxicities also seen. So this dose-finding study was really conducted because in earlier data, there was a concern about cardiovascular and bleeding events, and at this dose, it was not felt ultimately that there was a greater proportion of cardiovascular events such as QT prolongation or bleeding events compared to best available therapy or other comparators. So this drug is approved in the United States. It's approved for thrombocytopenic patients, but I also find it intriguing that even though we can use it at any platelet count, which is I think the main niche here, in the clinical trials in PERSIST-2, there was actually some improvement, clinical improvements in hemoglobin, reductions in transfusion burden, less transfusions needed over the course of studies. So not only has this met a need for very thrombocytopenic patients, there's a chance that your thrombocytopenic patient might stabilize or improve their hemoglobin. And as I mentioned at the very beginning, treating anemia is really a very unmet need, as you all can experience or have experienced in treating myelofibrosis. So pacritinib dosing, again, we focus on those patients with platelet counts of 50,000. I avoid in patients with active bleeding or prolonged QT intervals. This drug, again, was on a clinical hold because of a possible excess of cardiac and bleeding events that was not felt to be a causal association, but the risk mitigation is to watch for these toxicities, to hold this drug before planned surgery or procedure, to reduce the drug if the patient has clinically significant bleeding or bruising or thrombocytopenia, to monitor EKGs periodically. And again, another practical point is have antidiarrheal agents on hand. So again, going back to this case, this drug can be used first or second line in a patient who needs a JAK inhibitor but has significant thrombocytopenia. So last, I want to focus on another JAK inhibitor called momelotinib. Those in the field who follow myelofibrosis are probably aware of this drug. This drug is not yet approved, but we think it's the next US approved drug for myelofibrosis. The original studies were called Simplify 1 and Simplify 2. And these randomized studies compared momelotinib to ruxolitinib in a JAK inhibitor naive patient population, or momelotinib to best available therapy in patients who previously used ruxolitinib. And the studies were initially disappointing, I'm sure, to the sponsors. There was a non-inferiority with spleen volume reduction, inferiority with symptom improvement in Simplify 1. In Simplify 2, better symptom improvement, but the same, essentially same reduction in spleen volume. So this was considered to be initially a negative study. It didn't really meet its endpoints, but the signal was there that there was improvements in anemia. So transfusion independence was much more likely in momelotinib treated patients compared to ruxolitinib patients or best available therapy patients. So another phase 3 study called Momentum has been done comparing this drug to danazol, which is used for anemia. And what it showed was achievement or meeting endpoints, symptom and spleen volume, transfusion independence. And so this is a drug that is actively being looked at by our US FDA as potentially the next approved JAK inhibitor. And its niche is for the patient who needs a JAK inhibitor but is significantly anemic. So how would I view JAK inhibitor sequencing? JAK inhibitors are the foundation of therapy. They're imperfect. There's room for other drugs, other mechanisms, but soon in the United States we could have 4 drugs available, 4 JAK inhibitors. So I sequence as follows. I use first line ruxolitinib unless the platelet count is low, pacritinib. Second line, I favor fedratinib as salvage unless the platelet count is low. For anemic patients in need, I would always look for a clinical trial, but I might think of momelotinib if this drug can achieve its approval. And I'm watching clinical trials. There are a few advanced clinical trials in phase 3 for novel agents. One is the BET inhibitor pelabresib in combination with ruxolitinib. This is in a treatment-naive population. The study has been completed. I don't have any data yet, but I'm looking at this drug, or I'm following this study in hopes that this would be a combination available to our patients. In phase 2, there was impressive spleen volume reduction, symptom improvement, 36% improving hemoglobin levels, some improvements in fibrosis. So again, I'm intrigued by this, and I'm intrigued by the addition of navitoclax to ruxolitinib. This is also in phase 3, comparing the combination to ruxolitinib. In phase 2, there were impressive responses in terms of splenomegaly reduction and bone marrow fibrosis. But again, we have to scrutinize in phase 3, and so I'm watching this for sure. So again, thank you for listening to my talk. I'm sorry that I couldn't be live. A conflict had arisen. I hope that this is helpful to you, and through through Dr. Agarwal and moderators, if there are questions about my talk, perhaps I can address them.
Thank you so much, Dr. Brady Elstein, for that wonderful lecture. And since our speaker is not there, we can discuss among ourselves. So I request all our discussions to please put the raise hand sign so that we can discuss among ourselves. If you've got any questions or we can have any discussion on any topic of myelofibrosis. Yeah, to start with, we have Dr. Gopinathan M with us. Dr. Gopinathan, your question, please.
Good evening, sir. Thanks for the very informative lecture. I'd like to just ask, how would you manage a case of AML who has progressed from MF? What would be the strategy?
So, Dr. Manoj Oni, if you can answer that one.
Yeah, so it's like a progression of AML from myelofibrosis. So I think the best strategy would be, giving a course of ASITD and following it up a allogeneic bone marrow transplantation.
So, anybody else, any other opinion? Or wants to comment on this? So I think first we can go for the immunophenotyping, whether it is a myeloid blast crisis or whether it's a lymphoid blast crisis. Depending upon if it's a myeloid blast crisis, we can go for AZA-ven and followed by maybe a stem cell transplant. The patient is fit for the same. Anybody else has any other question? So Dr. Gopinathan, any more question?
What is the time limit? I mean, suppose if you are able to deliver full dose of ruxolitinib, like 20 milligrams of BD. So what is the usual time that do we see in our clinical practice for spleen volume reduction, sir? Because many of the patients, we may not be able to deliver full dose of ruxolitinib like 10 mg BD because they have concurrent thrombocytopenia and all this. So if that is the scenario, what is the ideal time to wait for full splenic volume reduction?
That's a great question. Dr. Humaira, your question, can you answer that question? Raised by Gopinathan.
Hello.
Yeah, Dr. Humaira.
Yeah,
please go ahead.
I want to say that in our setting there is resource constraint. So when a physician find a patient with leukoerythroblastosis but do not find any spleen, in our setting, someone denied to say it as myelofibrosis, though patient has reticulin stain fibrosis grade 2 or grade 3. Can we say it myelofibrosis as patient has JAK2 positive grade 2 to 3 reticulin fibrosis but no splenomegaly?
Yeah, we'll come to that question of yours. But Dr. Gopinathan has raised one question before. He wants to know that if the patient has received not full dose of ruxolitinib, which is usually in the clinical scenario, not 20 mg BD, but maybe 10 mg BD or 15 mg BD and so on, because of the constraints of the platelet counts or financial constraints, what percentage of spleen volume reduction do you see in your clinical practice, and how much time does it take for the spleen volume to go down? Whether 2 months, 3 months, 6 months, or when can you say that the patient is not responding to ruxolitinib? That is what the question Dr. Gopinathan has asked. So if you can answer that question first, we'll go with the second question of yours then.
Okay.
Yeah. Any idea? So Dr. Prasanna, you want to comment on this?
Yeah. Thanks for the informative lecture, sir. It was a very nice discussion on myelofibrosis and its targeted therapy of JAK2 inhibitors. Usually in clinical practice, as Dr. Gopinath said, we used to start with low dose, especially if platelet count is the low borderline cases. 20 milligram BD or 15 milligram BD will be the ideal dose for our setting. And usually we see at least 50% decline from the baseline splenomegaly over the period of 3 months. So 3 months is the ideal cutoff where we expect at least a 50% of a spleen to get reduced. So this is we see in our clinical practice. And I have a simple doubt on top of it. Is there any biomarker which is available to monitor the response of ruxolitinib or to pick up early resistance of ruxolitinib? Any clinical biomarker or maybe a biochemical biomarker? So
to my knowledge, I think there is no biomarker which we can say that the patient is not responding. It's, I think, mainly because of just the constitutional symptoms and the splenomegaly size reduction, which
Yeah.
we need to monitor. But I think there is no other biomarker to my knowledge. If anybody has any other answer for this? I think to my knowledge, there is no other biomarker. Definitely by the end of 3 months, if there is no response with
Yes.
ruxolitinib, then maybe the patient is not responding.
Absolutely, sir. We go by the clinical marker rather than a biochemical or a molecular biomarker. True.
Yeah, mainly the constitutional symptoms and the spleen volume reduction.
True, sir. Thank you.
I have a query. With 10 milligram, with ruxolitinib 10 milligram 12 hourly, can we wait for 6 months, or at 3 months we have to declare it as non-responsive? Can we wait for 6 months?
Dr. Prasanna?
Sir,
So what our question is basically, if the patient has been given a reduced dose of ruxolitinib, like 10 mg BD, can you wait for 6 months instead of 3 months?
I have not gone to such low doses, but I usually stop with 15 milligram BD, and I usually get a favorable response at least at 3 months. At least 50% of baseline reduction in the spleen size I have been observing, and it is more satisfactory clinical response at 3 months.
Oh, okay.
I have not used such low doses.
Thank you, Dr. Prasanna. Dr. Humayun, what your question was? Can you please?
My question was, I have a patient of 45 years, female, who has leukoerythroblastic blood picture. Atypical cells were 2 to 3%. NRBC were present. Patient has no splenomegaly, but she has JAK2 positivity, and on trephine biopsy, she has reticulin. She has fibrosis grade 2 to 3. So, though patient doesn't have any splenomegaly, some of our hematologists don't want to call it as myelofibrosis. Is it mandatory to have splenomegaly? Because in the WHO criteria, it is mentioned as a minor criteria.
I will go with that. So it is very true that because splenomegaly is in the minor criteria, because you've got all other criteria also, leukoerythroblastic blood picture, LDH level, splenomegaly, and so on, and anemia.
Yeah.
So if you're meeting minor criteria and you're meeting the JAK2 plus, if you're meeting the atypical morphology of megakaryocytes, according to WHO, definitely then you can call as early phase or pre-phase myelofibrosis also, where you may not find a splenomegaly. That's why we have got this pre-fibrotic phase of myelofibrosis, and then you got a fibrotic phase of myelofibrosis. So grade 2, grade 3 reticulin, atypical forms of megakaryocytes with bulbous nuclear chromatin, you have got clustering of the megakaryocytes, JAK2 positivity, or some clonal markers which are positive without a splenomegaly or a mild splenomegaly, but you have got that leukoerythroplastic blood picture with anemia. Definitely, you may call it as a myelofibrosis. Maybe it's a pre-fibrotic phase of myelofibrosis.
But previously, patient has a platelet count like 90 to 98,000, but suddenly for 1 month, her platelet count drops to 15,000, 16,000 like this. So I treat her with apheretic platelet and send NGS panel. Whether she could acquire new mutations or any other genetic mutations like this. Am I right in my diagnostic workup?
So if your patient has suddenly dropped platelet count within 1 month, I may still doubt the diagnosis now. Because
patient's diagnosis was in 2019. Now it is 2023.
Oh, then it's quite obvious. Then it has progressed. Definitely.
Yes.
So you have to repeat your bone marrow biopsy. You have to repeat your cytogenetics. You need to repeat your NGS panel also to see the progression of the myelofibrosis, whether it has entered into blastic phase of myelofibrosis or whether some new mutations has arisen.
Yeah.
Maybe both in the terms of cytogenetics as well as molecular genetics. So, right. So anybody else has any other question? So one question has come up from the audience. Dr. Kanan has asked question. Dr. Kanan Ramamurthy has asked a question. A 50-year-old patient with severe myelofibrosis at presentation, triple negative with no clonal markers in cytogenetics or NGS, no other autoimmune markers. Patient meets the transplant criteria and is fit to undergo the transplant. Will you do transplant, or would you like to rule out autoimmune myelofibrosis by giving steroids for 2 to 3 months to see complete reversal, especially here where there are no clonal markers? So, Dr. Manojuni, if you can answer that question. I repeat the question: 50 years patient with severe myelofibrosis at presentation, triple negative, JAK2, CALR, MPL, all negative, no clonal markers in cytogenetics or NGS. There are no autoimmune markers. Patient meets the transplant criteria, but is very fit to undergo transplant. So would you want to rule out first autoimmune myelofibrosis by giving steroids for 2 to 3 months before going for transplant?
Yes, surely, because there's no reason why we should not deny him medical treatment before being completely sure that it has not worked, and then go for transplant will be fine. So a course of steroids is perfectly acceptable, especially when there is no clonal markers. We should in fact give for a trial of steroids, and then if that doesn't work, then everybody's convinced that transplant is the only option left.
So anybody else, any other opinion for this? Dr. Prasanna?
Yeah, I concur with Dr. Uni, because it's a triple negative one and no clonal biomarkers being available. So we can give a empirical course of steroids, and then we'll review the patient after 3 months, and then we'll go. Yeah.
Dr. Gopinathan?
No, sir.
Yeah, would you like to go for steroid first? In this case, Dr. Gopinathan? Okay. So, Dr. Humaira?
No, sir, I agree with Dr. Manoj.
Okay, and Gopinathan? Dr. Gopinathan? Fine. I will also go for steroid first, a trial of steroids, and maybe plus minus danazole in this case. If the patient is responding, it may be a case of autoimmune myelofibrosis. I will also, because patient has not been done, any autoimmune markers are negative. I think the audience means that ANA is positive, ANA is negative, RA factor negative, DCT negative. So definitely I will give a trial of steroids first, and the patient is responding, well and good. If the patient is not responding, then we may proceed for the transplant. I have a question actually for all of you. A patient of mine is a case of 28 years male, direct cum test positive, severe myelofibrosis on bone marrow biopsy. But the megakaryocytes is not of that typical variety of myelofibrosis. Direct cum test is 3+ positive. Erythroid is markedly suppressed. Megakaryocytes are increased, but there is no ATP in the megakaryocytes. Grade 3/3 reticulin fibrosis. RA factor negative. ANA is negative. Thyroid function test is absolutely normal. Whole ANA profile was done. Again, that was no relevance was given. There was no significant antibody found in that. So how would you manage this case? Dr. Uni?
Yeah, so there's a young patient with severe myelofibrosis, and so
Yeah.
I mean,
Young patient, 28 years male, direct cum test is 3+ positive, and grade 3/3 reticulin fibrosis. Megakaryocytes are increased, but there is no ATP as such, which you see in a classical case of myelofibrosis. There is a mild splenomegaly. Erythroid is markedly suppressed. Direct cum test is 3+ positive. LDH is 345. RA factor negative. ANA negative. Thyroid function test normal. LFT normal. Creatine normal. Hemoglobin is 3.
it's a difficult question, but I feel because of the AN 3+ DCT, I would still give a trial of steroids at first before going further into thing of transplant, because there is some autoimmunity looking at the DCT 3+, and he's young, so we should exhaust all possible treatment avenues before embarking on the transplant way. So I would prefer to give a course of steroids first, and see how he responds.
True. I worked up further of this case, thinking of it can be a case of maybe DCT positive pure red cell aplasia with autoimmune myelofibrosis. So I worked up further, looked a question for whether the patient has got combined variable immunodeficiency along with it. Immunoglobulin levels was sent, IgG level was low, IgA was low, and IgM was also low. At the moment the patient was started on steroids, patient ended up with severe opportunistic infections with Clostridium difficile toxin induced diarrhea once the patient was started on steroid, and all other many opportunistic infections patients also landed up. So I had to reduce the dose of steroid, and right now the hemoglobin is maintained around 9.5. So what would be the future management plan of this patient actually? Dr. Uni, you
Yes,
can
so there is a inborn.
Yeah, please go ahead.
Yeah, so now from the history, it looks like he has a congenital immune deficiency. So
Yeah.
for that, I think only transplant will help him.
So future only the transplant would suffice.
Yes.
Yeah. Thank you. Another question, we have so many questions are coming from the audience. I read out the question. Dr. Sinwin has a question. How much erythropoietin is used for patients who are requiring transfusion in a case of myelofibrosis, particularly when the erythropoietin level is very low? So Dr. Gopinathan can answer this question. Dr. Gopinathan?
Yeah. So we can start with, if it is low EPO levels, then we can start with 10,000 units weekly, and then escalate it up to 40,000 units twice per week. So maximum 80,000 units per week we can go for the entire week to achieve the desired response. And to achieve the desired response, we can wait for a total of 8 weeks duration. Like one dose, if we start with, say, for example, 10,000 units, we can wait up to 8 weeks to achieve that desired response, to take a call whether it is actually responding or not responding. And subsequently, we can escalate.
Absolutely. Thank you so much. Dr. Ashraful Haq has a question that whether there is any role of lenalidomide or thalidomide in myelofibrosis. Dr. Gopinathan?
Yes, we do find in some cases there is a beneficial role of thalidomide in controlling splenomegaly, and particularly when they have anemia. We do find this a bit helpful. Same like the thalassaemic patient with a splenomegaly and anemia. I mean, the very huge splenomegaly, thalidomide helps in controlling the splenomegaly. In particularly MF isolated anemia, splenomegaly, there is a beneficial role of low dose thalidomide.
So how much low dose thalidomide are you using in your clinical practice?
50 milligram OD.
And then you continue indefinitely?
Indefinitely, yes.
And what is the dose of len you can use?
Len, actually, I have not used much, sir. Maybe we can start with, because cytopenias might be a bit problematic, we can start with 15 mg, 10 mg. 25 will be a bit prohibitive.
Perfect.
I have a query. Can we use danazol to treat anemia in myelofibrosis along with thalidomide?
Yes. We can. Danazol 200 mg TDS. We can use to treat anemia along with thalidomide.
200 TDS. In my practice, I use 200 BD.
Maybe.
We can give it up to 3
yeah, we can monitor on the basis of LFT. We can go up to 200 TDS. If there is some degree of liver dysfunction, maybe at that point of time, you may need to come down on danazol. Otherwise, we can continue 200 mg TDS.
Okay, thank you.
Okay, thank you, Dr. Humaira. Thank you, Dr. Gopinathan. Another question is from Dr. Sanjukta Rao. In a case of severe thrombocytopenia with primary myelofibrosis, triple negative, but with leukocytosis to the tune of 75,000, what are the options when pacritinib is not available in a country like India? So, Dr. Prasanna?
We limit ourselves to ruxolitinib or fedratinib now, but since pacritinib is not available, so we limit until that. So 75,000 probably will be the cutoff, and we can modulate the dose according to that. We limit ourselves.
So if the patient platelet count is, say, for example, 30,000 and the WBC count is 75,000, then what dose of ruxolitinib we can use?
Probably 10 milligram BD or 5 milligram, maybe I moderate.
Maybe the lowest possible dose. I think
Yeah, lowest possible.
along with maybe we can go for hydroxyurea. So great. Anybody else, any other answer for this?
My approach is also same, sir. Like ruxolitinib 10 milligram BD I keep, and hydroxyurea I add to keep the leukocytosis under control.
True. Perfect. Dr. Sinwin has a question. Which one is better, thalidomide or lenalidomide? Dr. Gopinathan, you can answer this.
Thalidomide is my personal preference. So I have seen it less problematic than lenalidomide to use in clinical practice.
Dr. Manojuni?
Yes, same. I have not used lenalidomide. I've always used thalidomide, and they're definitely easier. Maybe it's long term. We have used it for long, and so we're biased. But thalidomide is much more, and it's a small dose of 50 milligrams. And if people tolerate very well, I see no reason why we should think of len.
Absolutely. So we are very friendly with thalidomide actually. So another question is from Dr. Nikhil. If the platelet count falls to less than 50,000 and the patient is on ruxolitinib and ruxolitinib is stopped abruptly, do we get a risk of withdrawal syndrome on stoppage of ruxolitinib? And for that, should this be tapered and stopped slowly in this setting or when there is no response? So that is the first question. Dr. Uni, you want to answer that question? Would you stop
abruptly? No, I wouldn't stop ruxolitinib abruptly because cytokine release syndrome can be very fatal, in fact. So definitely it requires only a tapering and probably with steroid cover because that will prevent any CRS and its attendant complications. So a tapering along with steroid cover should be considered at this point.
Perfect. And he also wants to know what is the role of routine vaccination in primary myelofibrosis?
I don't have an answer because I will not be doing it routinely as a practice.
Anybody doing vaccination for primary myelofibrosis patients? Dr. Gopinathan?
So scientifically, it sounds logical to vaccinate for the at least encapsulated organisms, at least pneumococcus and meningococcus, but we don't see much of infections in MF. So routinely, we don't do it before starting any induction therapy or unless the patient is post-transplant or something. In routine clinical practice, we don't usually do, but it's logical to consider because there is because splenic dysfunction, obviously, we do anticipate. I just want to take opinions from the floor also, like, do we practice?
Dr. Prasanna?
No, routinely we don't practice vaccination schedules in PMF. And I have another added question to splenomegaly part. Is there any physician who practices splenic RT for non-responding massive splenomegaly, symptomatic massive splenomegaly?
Splenic RT, we have tried. So is it splenic RT or splenic embolization, sir?
Radiotherapy.
Yeah, splenic radiation can be tried in refractory cases, sir. That we have done for 1 or 2 cases.
Okay.
But splenic embolization, I have come across in literature that it is quite, it doesn't help so much.
Yeah, me too. Splenic irradiation, we used to do a lot prior to the era of ruxolitinib, especially when we are in radiotherapy department. So, but after the introduction of ruxolitinib and other JAK inhibitors, the role of splenic irradiation has come down drastically in primary PMF. So that's what my experience in radiation.
True. So when the patient is on ruxolitinib, are you starting with any prophylactic antibiotics? And if so, which antibiotics and which antiviral? Nobody starting any prophylactic antibiotics?
No.
No.
No. Okay, so
But TB flare is quite common, no, sir? Post Rexulti. TB and viral is quite common post
yeah,
Rexulti.
Yeah.
so
Mm.
some of the
Is
settings-
it routine to? Is it okay to put Azivir and Septran? Is it?
yeah, because some of the
Yes.
speakers previously also mentioned when the patient they are starting on ruxolitinib for the first 2 months, many of them are putting on acyclovir as well as on bacterium prophylaxis,
Septran, okay.
but mainly for the first 2 months, and then after they just stop it if the patient is fit or nothing happens to the patient then after. So another question is, what is the role of pre-transplant Jakavi, check inhibitor?
In those patients who have a huge spleen, I mean, a massive splenomegaly, because carrying them over to transplant with a big, I mean, a massive splenomegaly will be a bit difficult. We may encounter poor graft function or, I mean, stem cell, I mean, homing to the native splenic organ. So in those cases, it's better to give a good amount of JAK inhibitors, get the spleen size down, and then take them for transplant.
So for what duration before transplant the patient should be in ruxolitinib?
Depends upon the, I mean, that is patient individualized. Depends upon, at least we need to achieve as low as 3 centimeter, 4 centimeter, at least to that extent. If you could achieve the splenic volume reduction, then it is safer to take over them
For the transplant. So yes, so answer is correct, Dr. Nikhil. So there is a role of pre-transplant check inhibitors, definitely decrease the splenomegaly, the splenic volume. So anybody else, any other question? I've finished the question from the audience. So Dr. Oning, you have any other question or any other case to discuss? Dr. Umaira, Dr. Gopinathan.
Yeah. So just want to know what would be the best condition regimen which you people here in the group use for myelofibrosis? I would like to know that. And what are the, GVHD prophylaxis you would try to give in this, just to know how the practices are. It's not a very common disease, so it's better to know.
Yeah. So Dr. Gopinathan, you want to answer that?
Flu, I mean, experience of transplanting in MF was a bit closer for me to answer this. Actually, flu BU-Cy or flu blue low-dose-Cy would be better. That is what we routinely do now for our AML patients. The same would help for this patient also.
Some of the patients we had used flu trio-Cy.
Flu trio-Cy.
Yeah. So, and I think that prophylaxis would be go for MMF or with cyclosporine. Or sorry, the methotrexate and cyclosporine. And then
Yeah.
after same GVHD prophylaxis, right? So you're using
Right.
methotrexate with calcium
Sure.
inhibitor?
Yes, sir. Yes, sir. Yeah.
Same, right. So that would be the GVHD prophylaxis. And
we encounter poor graft function, I mean, for quite some time. That's the usual course. Do we see that in the first 2-3 months of transplant?
yeah, that is a big problem with transplants in myelofibrosis.
Yes.
Many patients I've also seen developing poor graft functions in a case of myelofibrosis post-transplant. So yes. Yeah.
So we can always also consider giving romiplastin or trombobag after the transplant to enhance, engraftment. I mean, there's a role like that for some of TPO agents.
To my knowledge, actually, the role of TPO agents is not there in myelofibrosis. To
Post-transplant. Okay.
Post-transplant. Am I true, Dr. Gopinathan? Because I've never used any patient's romiplastin to just engraft in case of myelofibrosis per se.
No, sir. For aplastics we have used, but not for MF.
Not for myelofibrosis. Absolutely. Though patients of myelofibrosis, they do take time for engraftment.
Yeah.
It's a little bit of sometimes delayed engraftment in case of myelofibrosis. So that can happen.
That's why the cutoff, particularly for delayed engraftment, is
Right.
I think day plus. Yeah.
So anybody else? Any other question? So fine. So if there are no other questions today, the speaker is also not there. Dr. Humayra, you have any question you want to ask? You share your any case or anything, something?
No question.
Any case of myelofibrosis?
No,
Any
sir.
interesting case, whatever you feel like. Dr. Prasanna, your any case you have to share us?
Yeah, I have a very small query regarding fatigue associated with the myelofibrosis. So fatigue may be due to various reasons. One is probably the anemia and other inflammatory responses and cytokine release. But other than that, how physicians are tuned to treat fatigue associated with myelofibrosis? Can we use, is there any role of megestrol acetate for NDAs in the role of myelofibrosis related fatigue? I want to just know about it.
So Dr. Gopinathan?
Yeah, we can, sir. Even the conventional androgens, we can androgens be as the part of routine thing we use either menabol or nanosol. That relieves fatigue to some extent. And Megasty, as you said, increases general well-being, but not for quite a longer course. I think Megastrol just for a short 10-day course, that would do. Most of the patients do get symptomatically better. They come and report increase in appetite, increase in quantity of food that they take. So Megastrol, the Megasty 160 milligrams OD for almost 10 days that we use transiently. So with that, it gets a little bit better.
Thank you. Thank you.
In one of my patients, what I used was thalidomide prednisolone. That helped a lot to the patient, Thalpred. The patient always complained of fatigability, marked fatigability, but with Thalpred, the patient started feeling very much better. So I think that is mainly because of the autoimmune part of myelofibrosis.
Yes.
The entire mechanism of myelofibrosis is first autoimmunity, inflammatory.
Yeah. Thank you. Thank you.
Another question from Dr. KK Radhika. She has a case of 13 years old, CALR positive, high risk primary myelofibrosis, planned for transplant, and has got 10/10 matched sibling. He developed miliary tuberculosis after 1 month of JAK inhibitor, Jakavi, ruxolitinib. Patient initiated on anti-tuberculosis therapy. When can she considered that patient for transplant? So, Dr. Manoj Uni, you want to answer this question?
Yeah, I think after the course of ATT and subsequently when he's fit, we should go ahead. It is anyway, we cannot transplant him while he's on anti-tuberculosis treatment. After that, we have to take him off a transplant.
So we'll have to wait for the entire course to get completed and then.
Yes, course completed. Only then, yes.
Absolutely, yes. So another question from Dr. KK Radhika. Do you consider low dose aspirin in every case of primary myelofibrosis?
No.
No. Dr. Prasanna?
We don't routinely use antiplatelets. Otherwise, whenever the patient had some form of a venous event, related event, thromboembolic event, there is a role of antiplatelet. Otherwise, we don't routinely use it in clinical practice.
So just to add on with this question, I had a very similar, just 2 days back, I had patient who was JAK2 positive primary myelofibrosis being treated by me since last 8 to 9 years. This time, this patient came with a cortical venous sinus thrombosis. I did not go for the JAK2 burden, LL burden. The initial JAK2 LL burden was 84%. And the patient was on JAK inhibitor plus danazol plus Myelostate. WBC count was normal, platelet count was normal, hemoglobin was in the range of 11.5 to 12. On the top of this, he developed the cortical venous sinus thrombosis. Now the question is basically the patient was put on LMWH for 10 days, and after 10 days he comes to me. So now what DOAC can you use, or you can go for warfarin? How long? So these are the questions now. So Dr. Manoj Uni can answer that question.
Yeah, so we can put on DOAC after the period of LMWH, and it will require indefinite long-term anticoagulation because the primary pathology is always there.
So would you like to add both combined mode DOAC plus aspirin, or only DOAC is sufficient?
If you give both together, there's a little higher problem of bleeding tendencies. So anticoagulation on its own should be enough without ecosprin.
I think DOAC can work on both the part, venous thrombosis as well as arterial thrombosis also. It has got some role actually. So another question from Dr. Asraful Haq. Is there any role of splenectomy in case of myelofibrosis? Dr. Prasanna?
So after the introduction of JAK2 inhibitors, we don't go back to the age-old therapies of splenectomy and splenic artery anymore. Very rarely we encounter splenectomized cases with PMF.
True. Dr. Oni? You same? Or any other answer you have?
There is time you suddenly a massive enlargement of the liver, which you can't manage. So there's no role for splenectomy these days.
So, but suppose the patient has got mesospenomegaly, not responding to ruxolitinib, not responding to any other therapies. So would you go for splenectomy? A big spleen?
Yeah, if everything fails, yes, but it's more like he should know that it is not a foolproof thing, because he can have a very bad hepatic
Enlargement.
enlargement, and that can be very progressive.
True. So, Dr. Prasanna, you have got any other answer for this?
I'll go for splenic artery rather than splenectomy in refractory cases.
Absolutely true. So I have another question for all of you guys. So if the patient is on ruxolitinib, platelet count is, say for example, to start with patient platelet count was 15,000. WBC count is 12,000. Hemoglobin is 6. How do you manage this case? Confirmed primary myelofibrosis. Platelet count is just 15,000. Dr. Gopinathan?
At the lowest, lowest possible. As such, the drug leaflet says that less than 50,000, you need to be a bit cautious on using ruxolitinib. But in this case,
15,000.
Yeah, 15. Okay, so 5 milligrams BD of ruxolitinib, maybe with danazol. He has splenomegaly, sir. Splenomegaly.
He has got moderate splenomegaly.
Moderate splenomegaly. Okay.
So
ruxolitinib 5 milligrams BD with transfusion support,
No. Perfect. So I had another case of myelofibrosis. She's quite intolerant to ruxolitinib. The moment I start ruxolitinib, the patient becomes quite restless. She feels weakness, tired, hot sweats, hot flushes and all. So I have to stop ruxolitinib. Once I stop ruxolitinib, the patient is all well. And again, when I start ruxolitinib, again at a dose of even 5 mg BD, the patient has got severe problem. So anybody has encountered this type of side effect with ruxolitinib, where the patient has got all concerns with ruxolitinib after taking ruxolitinib?
No.
And one more patient I had basically on ruxolitinib, patient complained of severe leg pains. So does anybody encountered with severe restless leg syndrome like this on ruxolitinib? Because whenever leg cramps, yeah, very severe leg cramps.
This I had encountered in a couple of patients, sir.
Okay.
After starting ruxolitinib, this I have encountered in 2-3 patients. Severe leg cramps, they do come and complain.
Okay.
The thing is, I had for these things, what I did is actually I just decreased it to a minimal dose. Say if I'm giving 20 milligram BD, I decreased it to 10 mg BD for some time, and then subsequent I told them to increase hydration. This after hydration and some analgesics. After a month or twice time, then I increased back to 20. This I had encountered in few patients, but not very difficult to manage. Over 1-2 months time, these people eventually settled.
True.
Only thing what we did is just decreasing the dose,
okay,
and then subsequently increased.
Fine. So I've got another question. Basically, patient coming with at 45 years old, male patient coming with a blastic phase of myelofibrosis. So anybody has used ruxolitinib plus azacitidine in this scenario, combination of both, or would you go for aza plus ven in this scenario, followed by transplant? So ruxo plus aza plus ven, or only ruxo plus aza, or aza plus ven? So your opinion, Dr.
Aza plus ven.
Aza plus ven, no
Is that
ruxo,
plus one?
ruxo to be stopped.
Ruxolitinib, actually, it is fine. I mean, it's too jittery to. And in fact, I had a similar patient like this. For this patient, I continued ruxolitinib actually, but
Okay.
we went aza plus ven plus JAK inhibitor. It's what. But the patient was not responding to ruxolitinib at all, sir. On 20 milligram BD, he had the same spleen size. That means practically I think the drug is not working for him, maybe. So I don't think, like, even if we stop ruxolitinib, I continued for this patient, but even if we stop, I feel it would have not made a difference for him, I feel. So I will ultimately give Azamin induction. He lived for 3-4 months, and then ultimately he had natural course of disease has taken over. But he's quite elderly and frail, like 70-80-year-old male.
Okay. So the patient is currently on aza plus ven.
Aza plus ven, short course, 7+7.
Fine. I have another question. I've got a similar one case just 1 week back. This is a case of 58 years male patient who came to my clinic with a hemoglobin of 3, WBC count was 5,000, and the platelet count was 8 lakhs. The differential count shows 85% blast, myeloblast. Bone marrow biopsy showed a grade 3 fibrosis. So with a platelet count of 8.0 lakhs, grade 3 myelofibrosis, JAK2 was negative, no other clonal markers were positive, even on cytogenetics or NGS. WBC count 5,000, hemoglobin of 3, 85% blast, myeloblast, with grade 3 fibrosis in the bone marrow. JAK2 negative, KLR negative, MPL negative, no cytogenetic markers, no molecular genetics. How would you approach this case?
Okay. Quite a tricky and rare scenario. Okay. Usually in megakaryocytic type of leukemia, megakaryocytic types, we do see this kind of associated myelofibrosis in AML per se, like particularly in Downs. We can have this similar presentation. For this patient, if he is fit, we'll go with flag ven-based induction. Or if he is not fit, then in that case, HMA plus venetoclax.
Okay, so then followed by transplant.
Followed by transplant based on the molecular marker, obviously. Yeah.
Anybody else has any other opinion for this? Dr. Prasanna? So, yeah.
It's a deeply fibrotic marrow, so I'm a little concerned about giving the classical 7+3. I think aza-ven should be a combination which will pull the person through, and then if he's fit, then he's good for transplant. Because I think with grade 3 fibrosis, the conventional 7+3 certainly would be very toxic for this patient. And so I think aza-ven should be a combination, and then if he's in remission, he can be followed by a allogeneic transplant.
So I think as a ven, or better to go for flag-based regimen plus flag ven.
Yeah, the only thing is they may not recover fast with this flag therapy, because the fibrotic marrow certainly will. Of course, the cytopenia may be profound and prolonged. That's the only fear with intensive regimens like flag and 7+3, because grade 3 fibrosis, they may end up with some fungal infection in middle of the course, and it can be very prolonged. That's the only negative point, but otherwise it's not be wrong to give it anyway.
Any role of sequential transplant in this case? Sequential transplant?
Well, I've read it. I have not done it to anybody, so I can't offer anything my side.
Dr. Gopinathan, would you go for sequential transplant in this case?
Sequential transplant, I have to look over, sir. I have not encountered such scenario actually.
So I had one case before, basically, where we had gone for sequential transplant in this case. The patient was given Flemsa-based regimen and followed by a transplant. So Flemsa conditioning works both basically as induction as well as the conditioning part.
Conditioning part. Okay. So suppose if you are using Azavin based induction,
It's actually
suppose
a body situation.
okay. Suppose if you are using Azavin based induction for AML, sir, how many cycles do we do before proceeding for transplant? What does in commonly we are using in clinical practice?
So, Dr. Uni, you want to answer that question?
Yeah, we would give for sick people one cycle of Azaven do a marrow, and then we repeat one more before actually going for a transplant. So around at least two, I
Yeah.
think so should be. Not sure about the exact numbers, but definitely two will be given.
Okay. Right now, I have a patient, young girl, who had a similar scenario. Post only one cycle of Azavin, she went in for severe hypoplasia. So that a subsequent course of even Azavin, she's persistently cytopenic, like ANC is less than 100. To that amount of cytopenia, marrow is also showing aplasia, MRD negativity. Bone marrow is it's fully aplastic. I'm not able to get any cell. Like when I pull out an aspirate, only dry tap. It's more of peripheral mix, and the biopsy is totally hypocellular. In such scenario, is it wise to directly take them for transplant?
Yes. It is acceptable, Dr. Gopinathan, because another round of chemotherapy will may bring more infections and worse cytopenia. So, as a MRD negative with a hypocellular marrow, young person, absence of disease, we should go for allogenic if that is available without any delay.
Without any delay. Right.
Absolutely. Perfect. So, anybody else, any other question or discuss anything? And so I finished all the questions from the audience also. I think we can call it a day today. Well,
Yeah.
thank you so much, all of you, for joining this
Thank you.
evening. And we had a wonderful discussion today. And thank you, Dr. Novartis, for sponsoring us. I thank Dr. M.B. Agarwal sir to give me this opportunity to anchor this event, and specifically all the audience here to join us and ask questions and discuss with us. Thank you all the discussants. Thank you all the audience. Thank you, Novartis. Thank you, Agarwal sir. And goodbye to all of you. See you tomorrow at 11:30.
Thank you. Thank you.
Thank you.
Thank you.